Hi all. So myself Dr. Deepika and I will teach you or we will share the knowledge of Harrison together. So let's start this beautiful journey to read the Harrison. Um, Neuro is my favorite subject in medicine. So I will start the first topic of neuro itself. Let's bear with me. So first topic is the welcome all. First topic is GBS. GBS, as we all know, Guillain-Barre syndrome. Let's see the full expansion of this. Full expansion is Guillain-Barre-Stroll syndrome. So it is the demyelinating disorder. It is the demyelinating disorder and a neurological emergency. So demyelinating disorder. So it what we understand from this term. So it will affect the highly myelinated fibers more. So large myelinated fibers are affected more in this condition than the small myelinated fibers. The sensation which are carried by the large myelinated fiber, like the proprioception and the vibration, is affected more in this GBS condition than the pain and temperature which is carried by the small myelinated fiber. So why it is called neurological emergency, or why it comes under neurological emergency, I will tell you later, or we will see it. So it is an acute condition, severe autoimmune and fulminant demyelinating polyradiculopathy. One thing you should keep in mind, that it is a radiculoneuropathy, not the polyneuropathy only. It is polyradiculoneuropathy. So it will have the root pain. We will see later on. So it is an acute, severe autoimmune fulminant demyelinating polyradiculoneuropathy. So let's see the epidemiology of GBS. There are 1 to 4 cases per 1 lakh, and males are affected more than the females, and adults are having more incident than the children's. So one thing we should always keep in mind, that around almost all the cases, and around the 70% of the cases, there is some antecedent events, and that antecedent events is precede about 1 to 3 weeks prior to the onset of the symptoms. And these events are in basically, and most of the times this is in the form of some infections. Most common among these infection is Campylobacter jejuni. So we should keep in mind, if we have to take the history from the patient about some GI infection or genitourinary infections, or one thing we should keep in mind, some retroviral infection, or there are lot of infections which can cause the GBS, but most commonly is Campylobacter jejuni in around 30% cases. Others are HIV, human herpes virus, hepatitis E specifically. Others are EBV, CMV, Zika virus, Mycoplasma pneumoniae, Lyme's disease, lymphoma, SLE, influenza vaccine, and all type rabies vaccine. So these are the two vaccines, influenza vaccines and all type rabies vaccines, and these are the infections. And this condition like lymphoma and SLE can also leads to the GBS condition. So in this GBS, we should always know about the types. We know the AIDP type, that is demyelinating type, or axonal types. Axonal type, there are Aman, Amsan variants are there. So first, this AIDP type. What is AIDP? Is acute inflammatory demyelinating polyneuropathy. This is the most common type of GBS, and variant under AIDP is the facial variant, which manifests as the bilateral lower motor neuron type of facial palsy. This is AIDP type. Other is the Aman type. Aman is the acute motor axonal neuropathy. Amsan is the acute motor sensory axonal neuropathy. So these two are the axonal variants. Axonal variants are having poor prognosis in compared to the myelinating type. So Aman variant is acute pharyngeal cervical brachial neuropathy. We have to also know the variants under various types of GBS, because these are asked in exam also, and uh, it is also having the clinical relevance also. So AMSN having acute motor sensory axonal neuropathy, and the other type is the Miller-Fisher variant. Miller-Fisher variant, we have to keep in mind that it is having a triad. It is having a triad. Triad is areflexia, ataxia, and ophthalmoplegia. We can keep in mind by this O in numeric. O for ophthalmoplegia, areflexia, and ataxia. Areflexia without weakness. So, this Miller-Fisher syndrome can be in incomplete form or complete form. Complete form means it is having all three of these, and incomplete forms means it can patient can only have the acute ataxic neuropathy or acute ophthalmoplegia only without ataxia, and ataxia without ophthalmoplegia. So these type complete or incomplete form may be there. So but basically we have to keep in mind simply that it is having a triad, and triad can be remembered by the mnemonic OAA: O for ophthalmoplegia, A for ataxia, and areflexia without weakness. So, its variant is CNS variant, that is Bickerstaff brainstem encephalitis, and it is just the MFS plus altered sensorium. So this is the Miller-Fisher variant, and now comes to the antibody. This is the most important thing we have to keep in mind, and we have to learn that various antibodies, as we initially we have seen that is an autoimmune condition. So various antibody which are found in the various types of the GBS. In AIDP, this is anti-GM1 antibody. In Aman variant, this is anti-GD1A antibody. In MFS, this is anti-GQ1B. This we have to keep in mind, this anti-GQ1B. There is a full spectrum of diseases which comes under this one. We have see the Bickerstaff encephalitis, one is MFS, and there are other types also. We just know the these two things. Disease comes under anti-GQ1B syndrome. Okay, and one variant which we have seen under this Aman variant, that is acute pharyngeal cervical brachial variant. This antibody is anti-GT1A antibody. So this is very most important. Please keep in mind these are the antibody we have to learn by heart. AIDP, that is GM1, and Aman is GD1A. Aman variant is GT1A, and GQ1B, anti-GQ1B syndrome spectrum of this is this MFS and Bickerstaff encephalitis. So please keep in mind this. Okay, so I hope you are able to, I am contributing some of your learning, and I'm trying to simplify the things. Let's see. So clinical features. Clinical feature, it mainly presented, which classical description of the disease is it as an ascending flaccid paralysis. Flaccids mean areflexic, ascending flaccid paralysis, and description is basically it is that term given is rubbery leg, flaccid legs or ascending rubbery legs. Motor symptoms include the ascending rubbery legs. It evolves around the hours to days, and there is a plateau at around 4 weeks. After 4 weeks, the disease doesn't progress, and it comes to plateau at around 4 weeks. It is areflexic disease, so DTR are lost. I have already told you that bilateral lower motor neuron type of facial paresis is present in around 50% of the cases. Their most common cranial nerve involvement is the facial nerve also. Bulbar cranial nerve bulbar weakness can also present. If that is present, patient may present the aspiration pneumonia. Weakness of the pharyngeal or laryngeal muscles are there, can lead to the aspiration pneumonia also, and 30% cases require the mechanical ventilation. So you will see that here and there I am giving the percentage. Actually these percentages are important for our MCQ purpose. So let's try to keep in mind these percentage also. So these are the motor symptoms, and sensory symptoms involve the pain, as I already told. This is radiculoneuropathy, polyradiculoneuropathy. So pain is there, neck, shoulder, back, or diffusely over the spine, tingling over the extremities there. And this is the large fiber neuropathy. This is well understandable by the demyelinating, so it will affect more of the. It is autoimmune disease. Autoimmune disease produce the antibodies, and various antibodies will act on the myelinated fiber, that is large fibers, and that carry the proprioception and vibration sensation. So these sensation are lost, and this temperature and pain and temperature sensation is relatively preserved, or we can say the spared. Why it is spared? Because these sensations are carried by the small myelinated fiber. Okay, so these we have done with the motor symptoms, we have done with the sensory symptoms. Now come to the autonomic features. These are most important because initially I have seen that I have explained that it is come under the neurological emergency. Why it come under the neurological emergency? Because patient will have wild fluctuation of the BP, cardiac arrhythmias can occur, and others like postural hypotension, sweating, diaphoresis. These manifestations are most important, and patient can have various presentations. So GBS patients should be carefully monitored, and uh, there is some rule to shift the patient to the IC unit. We will see that rule, or we should keep in mind this thing. Okay, so I hope you are understanding. So let's proceed to the diagnosis. So we for diagnosis we'll see the nerve electrophysiology. Clinically we have seen, we will take the history, and by the features patient present, and after that we will confirm it by the electrophysiological study or nerve conduction velocity. In AIDP there is demyelinating variant, so it will have the myelin is gone, so it will be have the conduction velocity will be slow, distal latency will be prolonged, FV latency will be prolonged, compound motor action potential amplitude will be reduced. And in axonal variant, because axon is gone, not the myelin sheath, so conduction distal latency will be normal, CMAP or SNAP may be reduced. And CSF finding on lumbar puncture, we have all know the cytoalbuminological dissociation, in which protein is increased but no pleocytosis, because myelin is degraded na? So CSF protein is increased but no pleocytosis. When cells are also increased, we have to keep in mind that we should rule out the HIV. Okay, so cytoalbuminological dissociation, this is very important term, or we all know this. Okay, this is MRI. MRI is not so useful, but if MRI is done, there will be the gadolinium enhancement of the quada equina roots. Diagnostic criteria, we should keep in mind Brighton criteria. This is the named criteria, we should keep in mind Brighton criteria. So let's go to the treatment part. One thing which I want to tell you initially only, that there is no role of steroid, only two treatment modalities we are having, that is IVIG and plasma exchange. Okay, and this is treatment of GBS is very time sensitive. What do you mean by this? That after 2 weeks of the onset of symptom, immunotherapy might not be so much effective, and as at the 4 week plateau is already there, disease will not progress further, so no use of immunotherapy, right? So we have to give the IVIG as early as possible, and IVIG are preferable especially in the Aman and this MillerFisher variant, but IVIG is preferable in comparison to plasma exchange in other variants also. So dose is 2 gram per day. It is given in divided as the 400 milligram per kilogram per day for 5 days. Okay. So IVIG, we have to keep in mind the side effects of IVIG. That is all start with A, that is AKI, aseptic meningitis, and anaphylaxis, specifically in patients which are having IgA deficiency. Okay. So keep in mind these side effects also, because we have to know the side effects of IVIG. Okay, and this is for MCQ purpose also. Plasma exchange is this dose of plasma exchange is in the form of 40 to 50 ml per kg for 4 to 5 times over 7 to 10 days. Okay, so treatment, no role of steroid, and this I have told you already. So there are 2 treatment modality, one is IVIG, other is plasma exchange. IVIG is preferable. ADR of this side effects of IVIG and plasma exchange dose. So and as early as possible we have to give the IVIG. Okay, and one thing that is I was telling you that this mechanical ventilation, 30% of the cases will require the mechanical ventilation because of BP fluctuation, wide BP fluctuation, cardiac arrhythmia may occur, and the patient may have bulbar palsy. So there is some rule, that is 20-30-40 rule, to shift the patient to the ICU and to the intensive management for the patient of the GBS, that you have to read, and please let me know in the comment which you able to understand by that rule. Okay, so bye bye, thank you, and this is my first class. Hope you will like it. Thank you.